Our Tuesday Topics series this winter focuses on some of the many services and resources that the library provides to our community related to critical issues and topics in the news. Our topic today is healthcare in America, which has been found to be the top policy issue of concern for American voters. Central Library houses Health Central and offers health-based programs and services year-round, including Got Health programs and presentations on a variety of topics. Beginning in March, fourth-year medical students will be on hand here at Central Library to answer questions and guide patrons to health-based resources that they might need. Our presenter today is Dr. Teresa Green, Assistant Professor of Public Health Sciences and the Director of Community Health Policy and Education at the Center for Community Health within the University of Rochester's Medical Center. Following her talk, there will be an opportunity to ask our presenter questions, and then we will offer a short tour of the Health Division for anyone who's interested in that as well. Please join me in welcoming Dr. Teresa Green to our podium.
Thanks. Hello, everybody. Speaker works, that's good. So healthcare in America, that's not a very specific topic, and do it in a half an hour. So we're going to try. I'll touch on some important issues that I think we should be thinking about for healthcare in America. Hopefully you learn something and get a little tidbit. This is, of course, not an all-inclusive subject that I can cover in such time, but we'll touch on some important key points. I work at University of Rochester School of Medicine, and I work within the Center for Community Health and Prevention, which is right down the street on Prince Street, that has a lot of health education programs too. Feel free to peruse our website, and actually I have the link in this PowerPoint, which I believe will be available in some form, sounds like in many forms, for you all. And also work in public health sciences. I direct a course for the medical students called CHIC, which is Community Health Improvement Course, which we have Health Central partnership on, where our fourth-year medical students want to learn about community. So they partner with several community agencies in Rochester and work hands-on for the month that they're taking the course. One of those sites is Health Central upstairs, so 4 months out of the year, and hopefully more as next year rolls out. We'll have medical students here learning from all of you and hopefully helping you all through health education and some screening. So that's what brings me here. So healthcare in America. So yes, healthcare is in the news a lot, and many of us are very concerned about healthcare issues. This is just a perusal of the internet real quick in the last couple of days. Much going on, but the bottom corner, healthcare remains a top priority for American voters and will likely garner significant focus during all the speeches and all the debates, of course. And the State of the Union coming up tonight, we'll see what happens there. A lot of discussion in the presidential candidacy, and I was all set to talk about who won yesterday, but who knows who won yesterday, right? So we'll see. But, you know, the healthcare, the candidates, both Republican and Democrat, but more so Democrat, are really talking a lot about how are we going to fix the healthcare system? What are we going to do to fix the healthcare system? Well, what does the healthcare system look like currently? The big policy that is overseeing what the healthcare system looks like was set forth on this day when President Obama, just a moment there, signed into, I'm very out there with my political views, so please don't take offense. They're my views and only my views, but that's it. But anyways, loved Obama and loved that the Affordable Care Act was signed into act on March 23rd, 2010, which was really the largest piece of legislation governing our healthcare system and really tried to make big change in controlling primarily the cost, but also the quality of healthcare systems today. Certainly many flaws in the healthcare system, and certainly many flaws with the Affordable Care Act. And many things have been put in place since the Affordable Care Act that have really weakened the act of the Affordable Care Act. So many of the in my opinion, good things are kind of dummied down now. So certainly fixing is something that is necessary, or throwing the whole system out, right? But what does the system look like? So right now in the United States, we have many options for insurance, and that's primarily what the Affordable Care Act talked the most about, or at least in the press was the most prevalent. How do we get access to health care? How does everyone get insurance? And we've got a group of citizens there. If you happen to be very, very low income, often you can qualify for Medicaid, government-run program, run at the state level, but funded at the federal and state level. If you're over 65, you qualify for Medicare. Again, government-run program, Medicaid, Medicare. Medicare, run at the federal level, supported by taxes, and covers a lot in over 65. If you're in the middle ground and you have a job and you have access to private insurance, you quickly can sign up for private insurance, no problem. So the Affordable Care Act recognized that many people are in that middle ground, don't quite qualify for Medicaid, aren't old enough to qualify for Medicare, can't afford private insurance, so what are they supposed to do? And many people we find fall in this category. So the Affordable Care Act put together an exchange where all the private insurances, or those that wanted to play, could come together and compete for the dollar of those who are low income, moderate income, but are unable to get private insurance in the normal way or through an employer. And some subsidies were offered, still are offered to those who are very low income but don't qualify for Medicaid but can't quite afford it. The government said, well, if you're at this income level, we'll give you some leeway and you don't have to pay as much. That's what the Affordable Care Act put into place, the exchanges and the subsidies. They also made sure that everybody had to get insurance. And this is really important because that is what diversifies the risk pool. So healthy people had to get insurance, unhealthy people had to get insurance, 20-somethings who make money and don't think they need insurance had to get insurance. All that was important, and we know that that has since gone away. Another part of the Affordable Care Act is that in some states, Medicaid was expanded. So you didn't have to be quite so poor to be in Medicaid. You could be relatively moderate income and qualify for Medicaid, but not every state, because again, that's run by states. So some states did expand and some didn't. And then since then, the individual mandate has gone away. The exchange is much less strong. The subsidies are not paid for by the government. So a lot of this has kind of changed, but in general, that's what the system looks like. So is the system working? Well, if we look at the rates of uninsured, before the Affordable Care Act, our rate of uninsured was up to about 18%. So 18% of Americans couldn't access health care, did not have health insurance. The Affordable Care Act came along and we went down to a low of about 10.9%, 11%. So that's great. We covered another 10% of the American population with health insurance. Since the changes to the Affordable Care Act and over time, we're creeping back up, and we're at about 14% now of people uninsured. So still less than we were before the Affordable Care Act, but access to health care is not 100%. And most industrialized countries across the world do have 100% access to health care. We are one of the only one that doesn't provide that. So, is that a good thing? Is that a bad thing? And that kind of depends on your thoughts on it all. So what are the candidates proposing? What are we looking forward to in the future? Well, there's a lot of terms being thrown around: single-payer system, universal health care, and this idea of Medicare for all. So single-payer system means just that one person is paying for all insurance, and often that's the government. And that sort of is the Medicare system right now, although Medicare is contracting, they're paying, but many people are providing insurance. Universal health care is what we don't have here, where everybody has the same system, everybody has access to health care. We don't have that, and a lot of people are saying, yeah, we probably should. And then this idea of Medicare for all, mostly because folks understand what Medicare is, right? It's a single-payer system. It's sort of universal, but just for those over 65. Should we expand that and have coverage like Medicare for more people, or maybe all people? And we have many candidates who are on either end of that spectrum, right? And just thinking about the Democratic candidates, Bernie Sanders is all about Medicare for all. We should get rid of private insurance immediately. Everyone should be on a single government-run plan that provides insurance for everyone, equally across the board, no matter your age, no matter your income. Elizabeth Warren says, yep, I believe in Medicare for all, but in December kind of came out with a little bit of a step back from that, in that we should kind of segment in, because removing the entire insurance industry will be very earth-shaking to the U.S. economy. And how do we handle that? And will people get behind that? And is that a viable option in the political climate these days? Who knows? So she's kind of taking a step back to say, let's work on it incrementally. Maybe we start with a public option, but still keep public insurance, private insurance, and then working towards a single system in a couple of years. Pete Buttigieg believes in Medicare for all who want it. So right now you can only get government public insurance if you're over 65 or if you're income eligible, but he's saying anybody should be able to buy into that plan because it's a less expensive plan that will bring down the prices in private insurance. So that's an interesting thought. None of the candidates have really come out with how we're paying for this system, how we're going to handle the obliteration of all the insurance companies in the country, how all those people are now going to be employed. I mean, there's a lot of ifs, ifs, ifs on this, right? Andrew Yang says, yeah, I believe in Medicare for all, but really we should be thinking about the root causes of the high cost of health care, and I agree with that 100%. What's going on with prescription drugs? What's with all the waste? How do we fix the system to be less expensive? Amy Klobuchar talks about practical healthcare reform. Again, that this whole big overhaul is not going to be feasible. People aren't going to vote for it. So let's think of a different option. And Joe Biden is all about Obamacare, of course, because if you remember the picture, he was standing right next to President Obama in the signing. So he loves Obamacare and admits that things need to be fixed, but let's fix it instead of throwing away the system. Which of these do you agree with? Which of these do you not agree with? This is all what the debate is about right now. But I would argue that there's way more to the story than who gets access to health care. Now, of course, don't get me wrong, access to health care is critically important. If you are sick, if you need to go to the doctor, you need to have insurance in order to pay that. Bankruptcy should not be an option when you're debating about getting health care, right? Or health care should not be an option for fear of bankruptcy, which is clearly a problem in the United States. So what do I mean when I say there's more than that? What do I mean about health care being more than access to health care, or health being more than access to health care? Well, typically we go see a doctor, and that's the access to health care, right? That might be your preventive visit. That's, 20 minutes if you're lucky on a good day, once a year. Or if you're more sickly, a couple times a year, right? But what is going on in the rest of your life? Well, that one visit to the doctor is only one speck in your entire scheme of living, right? In the meantime, you live in a neighborhood, you live in a house that may or may not be healthy, you work at a job that may or may not support health, you buy groceries that may or may not be healthy, you have a social network that may or may not support health. So the other 364 days of the year, you're living in this environment that is very influential on how healthy you are. So when we're talking about fixing the system and keeping Americans healthy, it shouldn't be about access to health care when we're sick. It should be about what are we doing to support the environment that we live in to keep us healthy. And there's very little talk from the candidates, Democrat and Republican, about this, because this is the big problem. So how do we know this is a problem? How are we going to take a more comprehensive approach to health care? Well, doctors and researchers and economists have been thinking about this at the time of the Affordable Care Act, came up with this concept of population health, really thinking about health outcomes of a group of individuals, including the distribution of those outcomes within the group. And so we used to think about health as how many doctor visits and getting you healthy when you're sick. Now we're trying to think about what does our population look like as a whole? Not just the people that are coming to the doctor, but what does Monroe County look like? What does Rochester look like? And how can we keep that population healthy? The health department is key in this, right? Thinking about the population. Even at the clinic level, doctors are now being reimbursed on value-based reimbursement contracts, which are based on quality metrics of their population. So doctors are being held accountable to, if you see 1,000 patients, how many of those patients are obese? And what are you doing about it? So you might not have even seen that doctor, but you're being counted as, are you a healthy weight? Are you not a healthy weight? Are you a smoker? Are you not a smoker? Do you have your high blood pressure in control? Do you not have your high blood pressure in control? So we're thinking about populations of people, which is very different than we were 10 years ago even. And within that population, we're thinking about health outcomes, but also cost and also quality of care. So that idea of moving beyond just health care is brought about in the triple aim, and this is also kind of a buzzword that's been in the news, less so lately, but more about 10 years ago, but still guiding a lot of population health talk. What do we mean when we say triple aim? And that was invented by Don Berwick, although if you hear Don Berwick speak, he'll say his friend Frank actually thought of the idea, but he was chair of the committee, so he's getting all the accolades from it. I don't know who Frank is, but Don Berwick is quoted with coming up with the triple aim. And the triple aim says, if we really want a great healthcare system, fix the healthcare system, we're not just thinking about access to healthcare, which is the better care arm on the right side, but we're also thinking about how do we improve the population's health, and also, how do we lower costs of the system? And I'll show you in a couple slides why this is so important. We used to be just concentrated on the better care part, right? And even still with the Affordable Care Act and all the candidates. How do we get people into health care? How do we give good health care? But really now, we want to be thinking more about better health through improved health outcomes in the community, and how do we decrease cost? So when we're judging an optimal health system and we're trying to fix the American healthcare system, is the American healthcare system broken? First of all, do we think, as many people do, that we have the best healthcare system in the world? Or do we have the worst healthcare system in the world? So who thinks we have the best healthcare system in the world? Who thinks we have the worst healthcare system in the world? A couple of you. Who thinks we're probably good on some things and bad on some things, right? Exactly. So we're good on really great technology, right? Really good state-of-the-art care. If you've got a rare disease and you're living in Pakistan, come to the United States because we're going to fix you, right? We've got the technology, we've got the education, we're really good at health care, right? But we're not so good at controlling costs, and we're not so good at improving health. The other two arms of the stool, right? So how about cost? Well, this is the trends of the United States in cost on healthcare over time. All the colors are every other country. And the United States is the black line that is growing tremendously over time. And we've really broken away from the pack on how much money we're spending on healthcare every year. More currently, this goes up to 2016, still breaking away. All the other countries, Austria, Canada, Germany, Switzerland, much less expensive than we are. So, and this growing cost is hurting the United States economy. Out of the dollar that we spend as U.S. citizens in taxes, close to 30% goes into healthcare. That's money that's not going into infrastructure, education, military, unemployment. Everything else is all the rest. This little area on the end here, housing, energy, international affairs, science, transportation, that's this little square, all of those things, right? But healthcare is this whole big branch. This is unsustainable, 30% and growing every year. That's too much money, right? So that's okay, though, if all that money is getting us really great health outcomes, right? I'd pay to know that I'm going to live a really long time and have a very healthy life. But unfortunately, that's not the case. We're paying a lot, and yet we're not getting the outcomes that we should be getting. So our total life expectancy is much lower than all other comparable industrialized countries. So we're paying a lot, but we're not even living as long. broken out with a couple of countries. The United States is on the bottom, and 4 other countries at least are much better than we are. So our life expectancy is about 79, and we've got 84 in Japan, 82, 81-ish on others. So not only are we lower than other countries, but if you notice in the last 2 years here, our line is going down. So not only are we worse than other countries, but our life expectancy is decreasing. And in fact, for the last 3 years, we have decreased. And that hasn't happened in many, many years. So why do you think that our life expectancy is decreasing? Anybody have ideas on why? What the cause is? Opioids is one. And you know what the other one is? Stress leading to? Not obesity. Suicide. Yeah, but that is a chronic disease problem. But obesity and suicide and opioids. What a horrible thing to be decreasing our life expectancy on, right? Nothing to do with access to health care and who has insurance, right? Although certainly mental health and access to mental health providers, which is a whole nother story. But these problems of despair, they're called, or diseases of despair, suicide and overdose, are causing our life expectancy to go down. So, if you put these two things together, health outcomes and how much we're spending, on the right is how much we're spending, on the up and down is our life expectancy, but you could do any health outcome. All countries kind of fall along this line. If you spend more, you get better health outcomes. And Switzerland is doing it right. They're spending a lot, but they're getting really great health outcomes. They're the final one. I'm not sure how well you can see. Spain, UK, Japan. So where do you think the US is on this? Which block are we? Well, you guessed it. We're way over there. Right? We're spending twice as much as the next country, and our health outcomes are nowhere close to where they should be projected there. So what's the problem? We're spending all this money and we're not getting the health outcomes. Well, people are thinking about this now, finally. What is the problem? Well, one problem is where we're spending all our money. So here's from 2017, that's the most recent one. The money we spend on healthcare, 33% goes to hospital care. Again, access to care when you're sick, right? So we spend a lot of money in the hospitals. We spend a lot of money on physicians. We spend a lot of money on drugs, dental, professional services. How much do we spend on staying healthy? Well, in the other category, all of this is broken out, and we spend 3% on public health activities, which is the building healthy environments, keeping screening going, education, all the things that we come in contact with in our day-to-day lives to stay healthy. 3% of that dollar, right? But, what is it, 30, 50, 60, 70% over here in healthcare. So when we're sick, we do a really great job because all our dollars are going there. But in staying healthy, not so much. And people are studying this. There's a great book called The American Healthcare Paradox, if this is interesting to you, that talks about we're spending money in the wrong places. And countries who are really doing a good job with life expectancy and health outcomes are spending money on the social spend, which is keeping us stress-free. Somebody over here said stress. Relaxing, right? Vacation time, education being paid for, home health care when you need it, people coming to your house to take care of you when you have babies, things that support healthy living and not necessarily health care delivery. So we spend the least on social care right here and the most on health care. Some of these other countries are spending a whole lot more on social care and less on health care, but their health outcomes are much, much better than ours. So their ratio is working better than our ratio is, and we should think about that a little bit. So why are we dying? That's when we're measuring life expectancy, what should we do to keep that life expectancy, so to stop dying and to stop dying young? What are people dying from in Monroe County? Anybody know what the number 1 and number 2 are? Diabetes. Not diabetes, further down the chain. Heart disease, somebody said? Heart disease, yep, and what else? The big C, cancer. Heart disease and cancer, Heart disease and cancer have been number 1 and number 2 for a long time. This is 26, 15, 14, and 2009. Neck and neck, cancer and heart disease. So how do we stop cancer and heart disease? So we don't wait till people have a heart attack and treat them, right? Maybe it's more about healthy fruits and vegetables, healthy exercise, screening for cholesterol, all these things, education that we can get at Health Central. When we talk about population health and health outcomes, dying from heart disease is a health outcome, but we also said we wanted to think about the distribution of those health outcomes. So if we look at Monroe County, we know how many people are dying of heart disease and cancer. But if we break that down, like this very complicated chart that was put together by Common Ground, different races, for example, have different health outcomes. These are white people in Monroe County. They die from cancer and then injury and then heart disease. So heart disease seems to be treated in a way that leads to less people dying in Monroe County. African Americans, however, cancer and heart disease is way worse than among whites and Latinos. So what is going on in the African American population with heart disease? Do we need more screening? Do we need more environments that are conducive to healthy lifestyles that support heart health? Are we not doing a good job in the hospitals of treating African Americans with heart disease when they come into the hospital? These are questions that can only be thought about when we look at the population and the distribution of health outcomes across the population. So if we look at life expectancy in Monroe County, the US is at 78.8, like we talked about. New York's at 80, so a little bit better, and Monroe County's at 78.2, so in line with what the US is all about, a little bit worse than New York State. However, when we think about distribution, what is the distribution of outcomes within Monroe County? Is everybody in Monroe County have a life expectancy of 78.2? Well, in fact, that's not the case, and there is a difference, but, well, excuse me, there might be a difference. What do you think the difference is in life expectancy between those that live in Pittsford and those that live in Rochester? Do you think the life expectancy is the same? 2 years, 5 years, 10 years? 5, 10, 2? Good distribution. There you go. Well, guess what? It's 10 years. 10 years difference. So 10 years difference with, 10-minute drive? Why is that? Is it because there's less access to health care in Rochester than Pittsburgh? Of course not, right? University of Rochester's right here, Rochester General, or Rochester Regional. We've got great health care, and in fact, our area has very high, very low uninsured rate. So it's not access to health care. It's all the rest of it, the behaviors, the social environment, the living healthy. So let's explore that a little bit. This graphic, I think, sums up the whole thing. When we spend money, we spend 88% on medical services and about this much, 3 to 4% on health behaviors. However, health behaviors account for close to 50% of what makes us healthy. And this access to health care only accounts for 10%, it turns out, of preventable deaths. So we've got a mismatch in where we're putting our energy and our money and our news and our thinking about political candidates, right? So what about these behaviors? What are behaviors leading to healthy lifestyles? And this is just an example that we are measuring behaviors in our county and sometimes in our city. So for example, cigarette smoking in Monroe County is at 14.5%, but cigarette smoking in the city of Rochester is 22%. So much higher than Monroe and also the state of New York. And in the suburbs, much lower, so it kind of balances out. So really thinking about the distribution across the population is so important when we target interventions to make this better. Behaviors like consuming fast food. You know, we're pretty much in line with what the state is doing around that. Consuming one or more sugary drinks. We're at 21%. 21% of our population consumes one or more sugary drinks daily. Are you doing that? And 73% only participate in leisure time physical activity in the past 30 days. So 25% of our population in Monroe County had not participated in physical activity in the past 30 days. That's not so healthy, right? None of you, I'm sure. So if you're interested in more about the behaviors and what our city looks like and what our county looks like, I'm just putting there some websites. I'm not going to go into them, but Common Ground Health is a great place to start. That's the first one. Monroe County Department of Health has many reports on health outcomes in our community. And Healthy People 2020 gives you global what the country looks like. And the bottom one is the Center for Community Health and Prevention. Just another slide showing you that it has been researched what is leading to good and bad health outcomes. And we see that behaviors are really this 40 or 50%. Genetics counts for 30%. We can't do a whole lot about that. But healthcare only accounts for that 10%. All this conversation and money around healthcare. The social circumstance, and this will be my last couple of slides, the social circumstance really impacts all the things that we're talking about. It impacts access to care, behaviors, and even genetics, believe it or not, in the field of epigenetics now. There's a great graphic that I won't tell you about, or won't go into here, about how these social and environmental factors impact health outcomes directly, but also impact the behaviors. If you're in an environment, downtown city of Rochester, where there's not a lot of healthy fruits and vegetables, not great place to walk, not great place to exercise, you're going to have less healthy behaviors because they're not available to you. This has been explored in a new report from Common Ground Health called Overloaded, the heavy toll of poverty in our region. Not surprisingly, when we look at what our poverty levels and our socioeconomic status looks like in Monroe County, it mimics what the life expectancy map looks like, right? There's something to this. East Rochester has a lower SES, social economic status, and also lower life expectancy in a sea of high SES and great life expectancy. There's something to this. It's not just theory. It actually can be shown in data. If you're interested in more about poverty, there is a poverty report that's a couple years old now, but speaks to this issue of poverty that prompted the Overloaded report from Common Ground Health. And this can be found at the ACT Rochester website. We have a huge problem with poverty in the city of Rochester, so it's not surprising that the city has very low life expectancy numbers. When we talk about all this social circumstance, we're talking about poverty and economic stability because it leads to neighborhood and physical environment, education, food, community, and social context that all leads to less great health outcomes. So it's behaviors, but it's the underlying environment that leads to the behaviors that leads to poor health outcomes. And why are we not talking about this and funding this and working towards this? So a couple take-home messages. Access to health care is important, but not the major determinant of health, despite all you hear in the current news and all the debates happening. It is more important to stay healthy than to get health care. Of course, I'm not saying access to health care is not important. It is. But what are we doing to build healthy environments so that we're all staying out of the healthcare system? Healthy behaviors, screening, and more information is critical to this. And we need to fight to improve the social circumstance, which is underlying all of the behaviors and the stress that leads to poor health outcomes in all of our communities. That's the best way to impact health in America. The library is definitely working to do this. We have Health Central upstairs that has a lot of information. Sometimes my medical students helping with screening. We've got Goth Health lectures, and this is a picture from our medical students. And I want to close with just a thank you to the library because our medical students come here and they learn. And this was a picture that and this on timing for them, a picture that one of our medical students took when he was here in November, impressed with the knitting there to say that we must work together to make us all strong and more vibrant. So thank you for teaching our students, and I'm happy to answer questions. I'm sorry I went a little long.